I can get my slide going here. Okay, so the goals for today are to look at the prevalence and impact of urinary incontinence in the older adult population. I'd like to talk about what are the risk factors, do a little exploration of the pathophysiology of the different types of urinary incontinence, and then get into the meat and potatoes of how do we evaluate and how do we treat. So firstly, we have to have a common definition. We can consider urinary incontinence as any involuntary leakage of urine, regardless of etiology, by the way. You know, it's like always, you hear the expression, you know, pee in your pants, you're so excited. You know, so excitement could be, I guess, a reason. In terms of classification, there are basically three types, but there's the fourth, which we call mixed. And so the urge, stress, and obstructive incontinence. So we want to talk about the differences and how they're represented, and certainly about the mixed versions of that, which is basically a mixture of urge and stress incontinence. So in terms of the age-dependent changes, we always need to distinguish between that and disease in late life, right? Because there are some normal aging processes. So here you can see a graph that demonstrates the average or mean post-void residual urine, and that it increases with increasing age. And so this is just a generalization. Some people less, some people a little bit more. And as a consequence, as you see that volume approaching with late life, 100 milliliters of retained urine, it sometimes gets a little confusing as to what's actually age-related and what might be pathologic, particularly when we do bladder scans. And as I'm speaking in my the clinical office, I have my bladder scanner sitting right next to me here. So I'm reminded of, you know, when we use this machine. So the big problem is that the post-void residual urine tends to increase disproportionately in frail older adults. And that's because of what we call detrusor hyperactivity with impaired contractile function. A little bit of a mouthful, DHIC for short, I guess, for those that talk the talk of urinary incontinence. But basically, what you're having is a situation where the muscles in the bladder are somewhat, I call them like a Charlie horse. You know, they kind of get spastic, and they don't contract real well. So they're sort of undulating. I guess the equivalent in medical understanding would be the equivalent to a atrial fibrillation of the heart. You know, where the heart just can't get a firm squeeze as it flutters. We also need to think about what are lower urinary tract symptoms. A lot of times people call them LUTs. I guess depending upon what part of the country you're from, you can call them LUTs. It's tomato, potato, and whatever. But the point is that these symptoms are associated with frequency, nighttime urine, hesitancy, slow flow of urine stream, and perhaps a feeling that you're not completely emptying your bladder. And then just to, you know, point out that overactive bladder is another term that's used with the complex of symptoms called frequency and nocturia. So overall, the incidence of urinary incontinence is quite extensive, and it's not necessarily an age-related phenomenon per se, although it increases, but it's estimated that 25% of women experience some form of urine leakage. And as mentioned earlier, there's urge incontinence. So that's where you have the strong urge to urinate despite the bladder not being totally full. And we'll talk a little bit about how to address that in a therapeutic manner. Stress incontinence occurs when you laugh at a good joke. You might be lifting, a lot of times grocery shopping, you lift a bag. might occur with jumping and or coughing. So there are different precipitants, and it may be just simple walking that can cause stress incontinence. And then, of course, the mixed incontinence is a combination of both urge and stress. So a lot of money is being spent on urinary incontinent products. And I guess the good news is that, despite its prevalence, is that there are approaches that can really either eliminate urinary incontinence or alternatively reduce the symptoms substantially. In fact, I had a patient just a couple of weeks ago. Full disclosure, I'm always trying to get rid of urinary incontinence medications because they have anticholinergic effects. And so if it's not making any difference in somebody's life, I tend to say, let's deprescribe it just because of the medication burden. However, she says, no, I think it reduced my symptoms considerably. And so rather than going to the bathroom like 10 times a day, I'm only going 4 times a day. So good enough, so we kept the medication. And that's just as a reminder, always to look at patient, particularly older adult medications, to ask them if it's helping them in any way that they consider. That includes pain medications. And just as a caveat, some of the opioid medications used for pain after long-term use actually increase the pain rather than decrease it. And so when somebody complains that they've been on long-term opioids and their pain's getting worse, that's more than likely a side effect of the medication. So again, we're always looking for side effects. So just to talk about the prevalence in the community setting, as we said, up to around 25% of people have some form of urinary incontinence. That really skyrockets in long-term care. And in fact, one of the major reasons why patients with Alzheimer's disease end up in a nursing home is because of urinary incontinence. And the curious thing is that you're like COVID. When you have dementia, your sense of smell goes. And so a lot of times people walk into a nursing home and it has that urine smell sometimes, and that's a little offensive to people. But those that are cognitively impaired can't smell it, so they're not suffering from that, odor malaise. So that's just an important consideration to educate patients and their family members about that. Regrettably, women have urinary incontinence more than men. A lot of that is, as we'll see, is related to the pelvic anatomy, and then also probably compounded by childbirth. So in terms of socioeconomic or racial differences, Caucasians tend to have more urinary incontinence than other races. And just a general rule of thumb here, the younger you are, you're most likely to have that mixed pattern of urge and stress. Whereas with the old, you can remember the undulating, the fibrillating bladder, it's usually associated with urge incontinence. So the impact of urinary incontinence is pretty extensive. It can change social functioning. People don't want to get out. It reduces sense of well-being and your general view of your health. It could be viewed as an embarrassment. So it really does lower self-perception and can lead to additional social isolation and withdrawal, which are important considerations. The physical impact of urinary incontinence may include dermatitis, frank infections or cellulitis, worsening of either pressure ulcers or predisposing to pressure ulcers, particularly in the bedbound patient. And we've had presentations on pressure ulcers before, but I just want to remind everybody that turn people every 2 hours is the standard of care for those that are bedbound, but not necessarily evidence-based, because you can develop a pressure ulcer within 30 minutes as much as you can develop a pressure ulcer within 2 hours. And so we do use the turning every 2 hours as a standard of care, but I just want to remind everybody that's not really evidence-based. The other point of urinary incontinence is that it can predispose people to urinary tract infections, and we'll talk a little bit about what constitutes a UTI. And also it can disrupt sleep. So if you're up going to the bathroom all night long, not so good. And then also sexual dysfunction can be a consequence of urinary incontinence. So the risk factors are clearly age, obesity, so high BMI, probably even more so functional impairment. So if you just can't get up and get to the bathroom, you're going to have accidents, such as stress or urge incontinence. Memory impairment predisposes to urinary incontinence. Medications, so if you're on water pills in particular, diabetes and neuropathies associated with that, potential barriers to toilet access, such as being on a long road trip, and then also prostate issues for men. In terms of diabetes, what occurs is you get neurogenic problems, right? So that there's nerve damage. And so you get a bladder that's overactive because there's not a coordination of the nerves. And also there's a couple of classes of medications such as thioglutamine and gabapentin that can cause peripheral edema. And so then that predisposes to urinary incontinence, because particularly when you lie down at night, you might have nocturia because the fluids get redistributed as a consequence of their accumulation during the day. Also compounding urinary incontinence in diabetics is poor sugar control, so the glycosuria, or the spillage of glucose into the urine. Constipation is a big issue, and so always remember that not only for diabetics, but somebody that hasn't had a bowel movement in 3-4 days, thus actually not being called constipation, but rather obstipation, that can be associated with a fecal concretion that pushes the bladder over and causes incontinence. Also, peripheral vascular disease, PVD, can cause ambulation problems and then restrict people from getting to the washroom in time. So the problem with dementia is that there's more urinary incontinence because of not always knowing when to go, and also with mobility limitations. It's the opposite issue with, I guess, in a sense, that dementia is often associated with people not remembering to drink enough water, and so they get dehydrated. So there's a kind of a compounding factor here of fluid intake and bladder control. So we know that the pathophysiology of urinary incontinence has an age-dependent component. Part of that's due to the bladder not being able to contract. So you can imagine we experience generalized muscle weakness as we get older. So too we get bladder weakness, which is a muscle. We also get dysregulation of the nervous energy that goes to the bladder, and so we get these uninhibited contractions. So in other words, you really don't want the bladder to contract, but it's going to contract on its own anyways. And so a lot of it becomes mind over matter to try to get that bladder back into, spank that bladder back into control there. And we're going to talk about ways to do that. And then also with age, we tend to have a diuresis later in the day than in the morning. There's also elements of reduced sphincter tone. So the urethral sphincter, the rectal sphincter tend to get more lax. And then the bladder capacity is activated at lower volumes. And again, that's what, so lower volumes cause the bladder to start fibrillating, if you will. Okay, so we'd like to talk about the evaluation of urinary incontinence. So certainly it's, as you might surmise from what I've said so far, it's a multifactorial approach, right? There's a lot of reasons for urinary incontinence. A lot of it's associated with multiple morbidities, so you've got a little diabetes, or you've got pre-diabetic, maybe, you're on diuretics and so forth. So it all starts to add up. So that includes the medication concerns, particularly medications that can cause peripheral edema. As I mentioned, the thioglutamines, the gabapentins, and also, I suppose, the second generation of calcium channel blockers, such as amlodipine. And then the big one, quite honestly, of all of these in the evaluation is somebody's functionality. So we tend to use here at our Sanford clinic a gait speed, right? And so if somebody's less than a meter per second, we know that there's impaired functionality that we need to address. And it may be, use of a walker. It may be something as simply not having a night light in the house to navigate safely to the bathroom. So in our evaluation, the recommendation from the American Geriatric Society and other incontinence societies suggests that we should ask women, regardless of age, annually if they have any form of urinary incontinence, because half of them will not reveal this in their clinical encounters. They will just assume that it's normal, and why bother the provider with that information? And quite honestly, we want to be bothered with that information. So we encourage patients to, reveal and through structured questions, right? So the screening questions could be, do you have any problems with bladder control? Or can you make it to the bathroom on time? Or do you ever leak urine? So all of those questions are what we call icebreakers. And those can introduce the topic, because sometimes, quite honestly, people are not always, happy, or, they're just reluctant to talk about urinary incontinence, particularly if they have a family member there. It's another revelation that they, like the daughter who joined, grandma or their mother, they don't want to talk about that stuff, right? So if you get a positive response, do you ever have leakage, or you can't get to the bathroom on time? Then you start to break it down into, so do you lose urine when you do physical activity, like when you're gardening or bending over, coughing? And then in terms of that's stress incontinence. Urge incontinence is where you really got to go, right? Do you get to the bathroom fast enough? And then mixed is when, of course, you say one or the other, and you try to establish whether it's a prominent stress or urge version. And then if you identify somebody that loses urine in the absence of either urgency or physical stress, then you have to really start thinking about serious neurologic problems. And that's where we're getting into what we call the red flag symptomatology, a lot of times associated with spinal cord lesions from cancer or other conditions. So in terms of the history, when we evaluate urinary incontinence, we want to establish, when did it start? Is it like recently? Was it been going on for years? What's the frequency, of these incidences? Is it like, once or twice a day? Is it like all the time? And then also, as best possible, to try to establish the volume. Is there a little spotting on underwear or the pad? Or is it like a full-fledged, river? And then we also want to figure out what makes it better or what makes it worse. And so, obviously bending over, squatting, perhaps, exercising, lifting things, that may make it worse. Other things make it better, such as like, trying to hold your urine before you pee. And that's actually a therapeutic intervention. What about fluid intake? How much caffeine? I always ask people how much caffeine they're drinking. Not that it's necessarily evil, but you drink a lot of caffeine, you're going to pee a lot. So caffeine is good actually for asthmatics, because it's a vasodilator in the bronchioles. So a lot of times we tell these poor mothers with their asthmatic kids, if they ran out of some medication, I said, well, just give them a Coke. That used to be the old-fashioned methodology until we can get them into the emergency room. And then the Lutz symptoms, right? Those are the frequency, and all those other symptoms, nocturia, and so forth. You also can ask, do you use pads or any special garments? And then also try to understand what they've done in the past to help this. And a lot of times they'll say, oh, I got this medication and it didn't make any difference. So then, you think about non-pharmacologic interventions. A big question is, as I mentioned earlier and alluded to, was the association with bowel movements, right? So lack of bowel movements are as important as the loss of continence and bowel continence. So if they're fecally incontinent plus urinary incontinent, that's a red flag. And so you need to really do a little stronger understanding of the neurologic exam, which hint, hint, was one of the questions in the beginning. When you have these sort of red flag symptomatologies. You also want to ask about issues with depression, sleep apnea, or obstructive sleep apnea, which can also compound urinary incontinence. So again, the red flags are abrupt onset of urinary incontinence. If you have any level of pain, back pain or pelvic pain, that's an important consideration for a red flag. If you see blood in the urine, and I have to share with you, one time we had a dinner party at the house, and we served beets, which I don't think I'll ever do again, because one of the people who knew I was a doctor came out of the bathroom after eating the beets saying, "I'm peeing red. I think I've got blood in the urine." And I go like, no, that's the beets. So anyways, but yeah, any neurologic findings like new onset numbness, motor weakness, those are all red flags associated with urinary incontinence. So the other question is, how you want to ask, well, how is the urinary incontinence affecting the patient's function? What troubles you? What bothers you most about it? And how does the urine leakage affect your daily life? Again, trying to get at the functionality. And if somebody says, well, I just don't go out anymore, that lack of socialization is, believe it or not, is the equivalent to smoking 10 cigarettes a day in terms of health impact. So again, the cascade of urinary incontinence, social isolation, deterioration of health just goes right on down the line. It's important to look at medications, right? So you want to look at the ACE inhibitors, and particularly with, so ACE inhibitors, 10% of them can cause a cough. And so if I'm coughing all the time and I'm losing urine, well, that may be the ACE inhibitor, and you should switch to an ARB, instead. Calcium channel blockers can be associated with not only reduced bladder contractility, but also, as I mentioned earlier, the second generation, such as amlodipine, can cause ankle edema. And by the way, the ankle edema is usually prevented by preceding medications for high blood pressure with either an ACE or an ARB inhibitors. Already mentioned that diuretics can be associated with urinary incontinence, and opioids in particular can cause urinary retention, and equally importantly, they can cause constipation and sedation, which may lead to further functional impairment. And then the anticholinergics, so that Tylenol PM or NyQuil, those things that contain Benadryl in them, can lead to impaired emptying and urinary retention, a little known fact. In terms of the physical exam, we want to establish, and this is why we propose the geriatric 4Ms with each clinical encounter, that they should include the mini-cog. If they screen positive on the mini-cog, which is less than 2 minutes to do, right? It's 3-object recall, clock draw, and you're done. If that's positive, you want to go to the slums test, which is a little bit more extensive and establishes the level, is it severe, moderate, or mild cognitive impairment. In terms of functional screening, you can do the timed up and go test. You can ask them to transfer from one place to another, or you can ask them how they're functioning with their activities of daily living. And then finally, we've got the genital urinary exam. And so we'll walk you through a few of those components. So one of the things that often gets overlooked is the digital rectal exam. And so you want to establish that the individual has perianal sensation. And usually you start off by, when you do the external exam, that you touch the rectal area, and it should give a wink or a little squeeze. And then with the digital rectal exam, you also palpate, for either fecal obstruction, mass, or impaction. And then alternatively, you can look at the what's called the bulbal cavernous reflex, and that's where you either touch the clitoris or the glands of the penis, and you'll see the anal sphincter also create a wink. So there's two ways to elicit the response, and you can see in the picture here that there's two different pathways by which that occurs. In terms of the female exam, I think probably the most important part is just direct observation of either cystocele or a rectocele, where you see part of the vaginal opening press outwards when the individual basically bears down. And the male exam, you can see an issue, so there's issues with uncircumcised penis, where you've got so-called phimosis, or that's a constricture of the foreskin, and you can see the different gradations there. The type 5 is probably the most serious, because that can cause strangulation and gangrene of the penis. And then you can also get inflammation, non-specific, or you can get infections related, a lot of times associated with candidiasis, as you can see in the photograph there. So there is like cardiac stress tests, there are urinary stress tests. So you have somebody drink a half to a full liter of water, they get a full bladder. You can document that on a bladder scan if you wish. And then you just observe them after they do a deep cough, and you see if there's any expression of urine as a result of that. Other testing that you might consider is to get a urine analysis. We're looking for blood in the urine, sugar spillage. And then an important point, and I want to stress this, that if you have an elevated white blood cell count without bacteria in the urine, or if you just have bacteria without symptoms, those represent asymptomatic bacteriuria and not a urinary tract infection. So somebody has to complain of either having a fever, frequency, dysuria, pain with urination, to really qualify for a urinary tract infection, because there are now recognized individuals that walk around with bacteria colonizing their bladders. And by treating them frequently, you end up getting drug resistance bacteria, and you might actually accelerate the person's death, because they might get C. difficile colitis on top of a drug resistant bacteria. And so we're just much more cautious these days about treating urinary tract tests. So urine analysis are insufficient to say they've got a UTI. And I get this all the time. Somebody calls me up, and I'll have one of the staff members say, "Oh, did you see the urine on Mrs. So-and-so? It's a dirty urine." And I'm going like, "Yeah, and were there any symptoms?" Right? And so without the symptoms, you don't treat. Some of the other tests that we can do is a bladder diary. So you can see this from the National Continence Association. So you try to, again, identify the volume of lost urine. You try to identify how much fluid intake. And in the instance of doing a bladder scan, so you can do the bladder scan in the office, or you can refer them to ultrasound and radiology. They can do a pre and post. And so the post-void residual is particularly important in diabetics who may have a neuropathy. If you've known that they've had a urinary retention before, if you happen to know that a male has a prostate serum antigen elevation, and then a few of the other points that are listed here. Urodynamics, I grew up as a geriatric fellow, understanding and doing urodynamics, and quite honestly, I don't think they're done anymore. But they're pretty slick, right? They identify when the bladder starts to fill and it starts getting into those undulating contractions. There might be some instances where urodynamic testing is done for special reasons that we talked about before. In terms of treatment, it's most important to really establish the goals. Are we looking for a complete cure, or are we satisfied from the patient's perspective with a reduction in symptomatology. And so that's the whole point, is whether partial continence is considered a goal that we want to achieve. Oh, I want to go back to that and just say that, so achieving the goal is both a reduction in frequency of the bladder symptomatologies and also a reduce in the volume of lost urine. That's why you try to calculate how much urine is lost with each episode. Some of the treatment options that we look at are to eliminate contributory factors, such as not being able to get to the bathroom on time, maybe having a bedside commode or having a bedside urine bottle. Certainly, there's some lifestyle modifications we can talk about that include behavioral therapy. We'll talk a little bit about medications. And again, I've already done a disclosure on that, and my clinical approach is to not resort to medications right from the beginning. And then there are some devices that are available that include things like pessaries for cystoseals. And also we'll talk about neurostimulation, and then finally surgery. So here's the happy weight loss person. You can see the lots of food in the beginning and just, more modified foods in late. And I don't know that final figure there on the right. It looks like a Mai Tai or some sort of daiquiri. So I don't know how that works, because you're not supposed to drink alcohol if you're trying to lose weight. But anyways, so that's, I guess, artistic license there from whosever perspective that is. But clearly weight loss is one of the key and critical interventions. And it's tough because, the weight loss is always replete with all these programs that, first 3 months you lose weight, and then next 6 months you gain it all back again. So it's just this kind of seesaw going back and forth. So it's understood that's a aspirational and, difficult approach, but nonetheless, for those that do lose weight and sustain that weight loss, it substantially reduces urinary incontinence. I usually tell people not to drink any water after 4 p.m. or after dinner. So again, no evening fluids. Less alcohol can also disrupt the diurnal rhythm and also contribute to weight gain. And then caffeine reduction. Again, caffeine is a diuretic. And then certainly smoking cessation. So the behavioral therapy is, and I like this. This is from this picture here on the left came from University of California, San Francisco. They have a really neat web page if you want to look at interventions for urinary incontinence. But basically bladder training. And what you want to do is have frequent and scheduled urination or micturition. And so a lot of times you go every 2 hours, whether you need to go or not. So that's called scheduled toileting. You can also do suppression. So if you feel like you have to go, you just hold it and wait until it passes. Kind of hard to do when you're driving on the road and you go like, oh, I got to go to the bathroom. Well, try your best to, to do the suppression. And then perhaps the big thing over a intermediate term is the pelvic muscle exercises. And so those are the famous Kegels, Kegel. I don't know who Kegel was, but I guess whoever it was has got their name named after those exercises. And so the Kegel exercises help improve the urethral muscle, which is important, for holding the urine. It's particularly helpful in post-prostatectomy for men. In fact, I prescribed just a short while ago a prehab Kegel exercise, and the guy kind of looked at me and says, "Isn't that for the women?" And I go like, "No, it's actually for the men too." So it's equally effective for both genders. In the beginning, you want to do what's called high intensity and low repetitions. So you have that squeeze down on the perineum, or where I tell patients you squeeze in the area where the sun don't shine, but don't squeeze your butt muscles. It has to be in between the butt and the front of your pelvis. And You hold it just for a couple of seconds and you do those repetitively. But then eventually you try to build up to a count of 6 to 8 seconds. So you just count, 1 apple, 2 apple, 3 apple. And you want to do, the recommendation is do 3 sets daily. I quite honestly, I mean, if you do 1 set daily, probably good enough. And I usually tell people when they shower in the morning, that would be a good way to do it. And then when they go to bed at night. And if they can just remember those, first thing in the morning, late at night, you're going to get your Kegels in. In terms of medication considerations, you want to treat urge or the mixed, but not necessarily the stress. And so it's the urge incontinence that really gets the emphasis for the medications. And so there are antimuscarinic medications that are used for urge incontinence. And again, some people call that overactive bladder. And then if you have an urge heavily represented, in the mixed urinary incontinence, then it's also amenable to antimuscarinics. So basically what they do is they decrease the neurotransmitter acetylcholine, and it allows for an increased bladder capacity. So remember, the bladder is always trying to, squeeze, and so you're trying to get it to relax a little bit before it starts squeezing. But that's kind of the conundrum, right? Because as you get older, the bladder increases the capacity already. Now you're trying to make it, get more capacity. I don't know. It's theoretically, it makes more sense than practically, quite honestly. But the point is that there are some people that benefit from it, and they do get particularly benefit and increased quality of life as a result of both antimuscarinic therapy and behavioral therapy. There's currently, to my understanding, 6 medications that are available. There's no side-by-side analysis to say which one's better than the other. So that's the ditropan, the oxybutynin, those kinds of medications. The antimuscarinic side effects are something to consider. They're not particularly trivial. And although some of the medications are touted to be less side effects than others, don't believe it. There's cognitive impairment, short-term memory loss. You get also potential urinary retention, so you actually make the condition worse, and now you've got an obstructive uropathy as opposed to a urge incontinence. If somebody has glaucoma, particularly for closed-angle glaucoma, not good, contraindicated. Somebody's diabetic, it could exacerbate their gastroparesis. And if somebody's already constipated, particularly those on opioids, not a good medication to give. It also causes dry mouth. And I took a patient off of one of these antimuscarinic medications, and she says, "Oh, I don't have dry mouth anymore. How did that happen?" So it is an issue. Mirabegron is a adrenergic agonist as opposed to muscarinic, and that's just a different mechanism. You can see the chemical formula there. One of the issues is that it does have drug-drug interactions with beta blockers, and it can increase blood pressure. And so that's, for the hypertensives, which 85% of older adults are hypertensive, not an ideal medication in my book. So everybody uses duloxetine for everything. I mean, fibromyalgia, you use it for gastrointestinal, reflux. My gosh, I have no clue. I mean, duloxetine is like the miracle drug if you believe all the kind of indications. But again, it's off-label for urinary incontinence. The topical estrogens, mixed evidence, as to whether they work or not. Probably leaning towards people that remain sexually active in late life, that it might help, build with the vaginal tissue. Its impact on urinary incontinence, again, is mixed. And there's different, and I just put this little table here to show you that there's different options. There's gels, pills, there's even estrogen. So people with pessaries can have an estrogen-laced pessary. And compliance is an issue too. So you prescribe them, and the patients don't always persist, with using them. In terms of surgery or other interventions, so the minimally invasive ones are nerve stimulators. And so you can see a picture here of a internally placed or subcutaneous placed stimulator. They have external stimulators too that either stimulate the tailbone area or the tibial nerve, which is on the back of the leg. Botox has been used. It's again mixed reactions for its efficacy. The pessary is that donut-shaped object that's put intravaginally to address stress as well as urge incontinence, but usually associated is the word I'm looking for. Sorry, is usually associated with lax pelvic musculature. Surgery is colposcopy or colpal suspension. Sorry, a little bit tongue twister there, but basically you can see in the diagram here that there's a set of stitches that are used to basically lift the bladder up is what it does. In terms of surgery for men that have urinary incontinence post prostatectomy, there are artificial sphincters. I don't know the literature on that. I think it's also kind of a mixed bag as to whether they actually work or not. So thank you for posting the post-test there. And we're going to just wrap up here. The other treatments are to use pads and incontinence garments. Sorry, I got to advance my slide. Here we go. And then, in terms of resources, I'll just leave this up here for folks to take a look at. So you can Google a lot of this stuff. I tried artificial intelligence, ChatGPT. Yeah, not so good. So, I hope everybody saw the news that the recommendations of medications by ChatGPT were totally incorrect. I don't know if that's a campaign by any medical professions to discredit ChatGPT. But I also discovered actually today that ChatGPT is updated only to 2022. So it's 1 year behind on any information, at least medical information. So just kind of interesting reflection where the University of North Dakota just sent out a message from the president's office as to which faculty and which students are using artificial intelligence for research and for other, uses. And so they're trying to compile, what people are using artificial intelligence for. And we're actually doing a project on whether artificial intelligence images generated by this platform called DALL-E 2, DALLE, as to whether it has a bias towards ageism. And so far it looks like it does. So